All right, we're going to move on to the second half of our morning presentations. And we actually have a twofer. We have two of our pediatric dermatologists from Children's National who are going to do short back-to-back presentations. Doctors Habeshian and Kaiane. And we're going to take it as sort of a quick 1-2 go for it. And hopefully there'll be time for a couple quick questions at the end, but we'll hold the questions till the end of the session. So Dr. Habeshian, you're up. Thanks.
Thank you so much. I'll be talking about the management of acne vulgaris. I have no conflicts to disclose. This is my bio for reference. And these are my objectives. We're going to go through these in a case-based format. And then at the end, there's some reference material. The lecture will be posted just for tips and tricks in acne treatments. All right, and you can answer these questions to yourselves. This is just for you. So what is the best course of action for this patient? Topical retinoids, topical benzoyl peroxide wash, oral doxycycline, refer to dermatology, or all of the above? Yes, so all of the above. So this patient and these patients all have significant post-inflammatory hyperpigmentation and or scarring from their acne. Both can persist for a very long time and have a serious impact on quality of life. And so we do need to treat these patients aggressively. And I'm going to talk about oral antibiotics. There's some information about topical retinoids and benzoyl peroxide at the end, but I want to emphasize that when you see that much post-inflammatory hyperpigmentation or scarring, we're already sort of getting on the track of isotretinoin to prevent further damage. And so we do need to do oral antibiotics first. They work quickly and usually it's required for step therapy as well. And so this is indicated in moderate to severe inflammatory scarring or recalcitrant inflammatory acne or with severe PIH. The typical dosing is doxycycline 100 milligrams BID for most patients. For smaller patients, pre-adolescents, we'll do doxycycline 50 milligrams BID. It's important to counsel properly to take with food and water because nausea is a very common side effect and can be mitigated with food. To sit up right after taking to prevent the esophagitis, and then also to use sunscreen because it can cause photosensitivity. It can also cause headaches and rarely pseudotumor. And so there is a novel tetracycline, which is sarecycline, with a more narrow spectrum of activity. It was approved in 2018 for the treatment of moderate to severe inflammatory acne in ages 9 and older. But it's often cost prohibitive. This is a nice option in theory. I want you to know it exists. It may be covered by commercial insurances or there are coupons, but unfortunately it is often cost prohibitive for many of our patients. We avoid minocycline because the risk of side effects outweighs the benefits. There's a risk of liver failure, severe drug reactions, drug-induced lupus, so we don't use minocycline. And then Durham and ID guidelines recommend limiting the use to 3 to 6 months to help minimize antibiotic resistance, but we're often only doing this for a month or two to bridge them to isotretinoin. And so the bottom line is prescribe these in combination with the first line topicals. They're indicated for severe acne or even just for severe scarring or post-inflammatory hyperpigmentation. So feel comfortable starting all of those medications and referring to us for consideration of isotretinoin. Okay, case 2. This healthy 16-year-old has flares of inflammatory acne on the lower face monthly before periods. She's diligent with topical retinoids. Benzoyl peroxide burned her skin. A prior course of doxycycline was temporarily helpful. Her mom declines oral contraceptives as an option, and she does not want to wait until her dermatology appointment to talk about isotretinoin. What is the next best step? 1, add topical clindamycin. 2, prescribe another round of doxycycline. 3, discuss oral spironolactone. 4, no further treatment is available. Yes. So my correct answer is to discuss oral spironolactone. So this is a potassium-sparing diuretic, but it's used in dermatology for its anti-androgenetic effects. And we use it in patients who have what we call hormonal acne. All acne is hormonal, so it's sort of a flawed term, but what that refers to is acne that flares consistently before menses, and especially in the lower jaw and chin distribution, that tends to be particularly hormonally sensitive subtype. And as in COCs, we use it in patients who are postmenarchal for 1 year or greater. The acne doses are 100 milligrams typically, but we start with 50 milligrams daily. And if they're tolerating it, we can increase to 100 in a week. That can either be divided BID or taken all at once, depending on the patient, their preference, and the side effects that they're experiencing. We can increase it all the way up to 200 milligrams daily. It's important to tell patients the maximum benefit will be after 3 to 6 months. So it's not fast acting. So unlike doxycycline, it's not going to work quickly, but it's a safer longer term option because we don't have that risk of antibiotic resistance. And that's why I didn't like the answer choice of do another round of doxycycline, although in practice that may be done sometimes. And then as far as the topical clindamycin, this is in the reference material, but we don't use it unopposed without benzoyl peroxide because that increases the risk of antibiotic resistance. So if you could have treated that patient with a combination of topical clinda and BP, but because she didn't tolerate the benzoyl peroxide, that was off the table in this case. So the side effects are increased urination and dizziness. This is often temporary. The body often acclimates after the first week or so. Menstrual irregularity, which can be reduced with COCs if indicated for a particular patient, as well as breast tenderness, breast enlargement, headaches, and fatigue. We consider this a very safe medication for our patients, but there are contraindications, which are listed here. Essentially, any condition that raises the risk of hyperkalemia is a contraindication for spironolactone. So on that note, there's a lot of variability even among dermatologists and how comfortable they feel prescribing spironolactone, particularly in light of this possible risk of hyperkalemia. But the bottom line is that there's good evidence that in young, healthy patients, we're talking age 18 to 45, extrapolated to adolescents as well, who are not on potassium-raising medications are not at risk for hyperkalemia. So we feel very comfortable with this. And so this is based on 2 studies. The bigger one was a 2015 case control study with 1,800 patients that showed the risk of hyperkalemia in this age group was the same as the baseline rate in this population. And then a smaller study showed that, again, a similar percentage if you do the math below the age of 45, but that jumped exponentially above the age of 45. So for our patients that we're talking about, unless they are taking a potassium-raising medication or have another condition, we don't need to screen for potassium levels. And then just on another note for safety, there's a black box warning to avoid off-label use, which this is, by the way, for acne. It is off-label, given the oncogenicity in animal studies, but in human studies, 3 large retrospective cohort studies showed no increased risk of breast or gynecologic cancers, although we would talk to the patient about this if there's a family history. Okay. There is a topical androgen blocker that is newer that you all should know about. It's called clascoterone. And as I mentioned, it's a topical androgen blocker. So if a patient is worried about systemic side effects or doesn't want to take pills, this is an option. And it's approved for moderate to severe hormonal acne in patients age 12 and older, or boys, girls, everybody. And it's applied twice daily. The side effects are minimal. The redness, scaling, dryness, itching. It is cost prohibitive. It's a little bit pricey, as you see here, but for the patient with the right type of commercial insurance, there are copay cards and that can make this affordable. All right, case 3. You're evaluating this isotretinoin candidate. He has really, really bad scarring, as you see. And you'll ask if he's been struggling with depression, low mood, or sadness. He denies these feelings, but then scores an 11 on the PHQ modified for teens, which is consistent with moderate depression. Which of the following is the truest statement? 1, isotretinoin is contraindicated in depression. 2, isotretinoin is associated with a statistically significant increase in suicide risk. 3, isotretinoin has no effect on mood. And 4, isotretinoin is an appropriate option in patients with moderate depression if proper counseling and monitoring is in place. 4. Yes, and the best answer for me is 4. And so acne is associated with low mood. There are increased hospitalizations for mental health disorders in patients with acne. Survey studies showed an impaired effect on quality of life and even employment, comparable higher than that of asthma and epilepsy, and treatment of acne improves quality of life. Now, isotretinoin helps acne, but there is some bad press because there were case reports of suicide on patients on isotretinoin. But a review of the FDA adverse reporting system showed actually no increased risk of suicide and actually lower risk. Maybe these patients are being monitored more closely, but certainly there was no increased risk. And that's been replicated in meta-analysis subsequently, as well as a prospective study that looks specifically in patients with reduction, but there were severe decreases in depression scores in patients with depression. So our approach is we screen everyone with the PHQ-9 modified for teens. It's available in Spanish and other languages as well. And if they have mild depression, we proceed with isotretinoin, but encourage follow-up with mental health provider. And if they have moderate to severe depression or recent suicidality, we refer them to our clinical psychologist, Dr. Heyer, who works with us specifically with these patients, and she makes a further assessment and recommendations. The bottom line is that treating bad acne with isotretinoin improves mood in patients with and without depression and may decrease suicide risk, although we do need more studies. And this is just an example of the PHQ-9 and how we break down the scores. And then finally, this 9-year-old girl presents with her mother, who's surprised to learn that her child has acne, as she doesn't have her period yet, and is curious if it is treatable. Which of the following is true regarding acne treatment in pre-adolescence? 1, no available treatment is safe. 2, there are no FDA-approved treatments. 3, treatments are not as effective. Or 4, medicated washes and topicals are first line. 4. Yep, that is correct. And so first-line treatments are essentially the same for moderate to mild acne in pre-adolescence. We're happy to see patients if they have the more moderate inflammatory acne to talk about oral treatments in these patients. But certainly the first-line topical treatments are the same. They may do better with a wash just because of compliance, but certain hands-on parents will help with application of the cream. And then there are topical retinoids as well as oral sarecycline, which is approved in this age group. So the bottom line is you can treat acne very similarly and when it's more mild to moderate in pre-adolescence. And then I have reference material at the end, just so you know, to go back to about prescribing topical retinoids and benzoyl peroxides and trips to increase compliance, because that's often the tricky part. Oh, and that concludes my talk. Thank you very much for listening.
Hey, thanks, Kai. I actually learned a lot from that, so thank you. Yeah, it's okay. We'll scroll. This is actually very useful. How do you actually make acne treatment effective for your patients in terms of compliance? Because the dry skin is the biggest issue. So that will be helpful, I think, information. Okay, so I'm Yasmin Krikorian, I'm the chief of the division. I decided to do pediatric potpourri this year. So basically go through some hot topics after I, texted some of my pediatric pediatrician friends to see what they'd be interested in. I have no conflicts to disclose. Here's my bio. So let's start with this. We've got a few itchy babies today. So this itchy baby, supposed to light up. Okay. This itchy baby has eczema. So, eczema is something we see every day. It might seem banal, and yet it has this unbelievable impact on quality of life, in particular when it's severe. It really affects the entire family. It is the most common inflammatory skin disorder in humans, and severe eczema has an incredible impact on quality of life. Nobody sleeps. Everybody's miserable. And we should take it seriously, especially with that knowledge and with the understanding there are new drugs available even in our young children. It's also not just a skin disease. This is a common misperception, like, oh, their skin is itchy, like this will go away. Well, maybe it won't go away. So there's a lot of data that suggests that children actually can extend into adulthood with atopic dermatitis, but it's not only affecting their skin, it's affecting the sleep, which we know is critical to growth, to building memories, to cognition. It's associated with mood disorders such as depression, ADHD. There may be an association with obesity. And then there's major disruptions to school and work life due to severe eczema. This child here, I picked this photo deliberately because you might look at this and not immediately think, oh, that's eczema, but this is actually a variant called nummular eczema that we all see in our clinic. It's more common in children of color. It has this more sharply demarcated border to it. This is not tinea corporis. This is just a variant of atopic dermatitis, and you can see it's quite disruptive to the pigment in the skin in our children of color, and that is quite bothersome to the family, but also you have to keep in mind that when you treat eczema, especially these red plaques, they're going to look hypopigmented before the skin naturally repigments itself. So we kind of warn the patients it's not the medication bleaching the skin, it's that the eczema itself has caused the hypopigmentation that we're revealing by getting rid of the erythema with our medication. This is a whole family disease, like everything in pediatrics. It's not children who suffer alone, but the whole family. It's very common for parents to tell us, and they tell you, I'm sure, I sleep with the baby. I'm holding their hand all night so they can't scratch. Obviously, a parent who's holding a child's hand is not sleeping themselves. They miss school. There is often cases of low self-esteem and bullying, and I already told you about the mood issues. But the parents also will co-sleep. They're not sleeping together. They're sleeping. One is sleeping with the child. The other sleeping in the guest room. There may be lost work days. There's even data in adults of actual increased accidents, like car accidents due to poor sleep. So there's a lot of impact on this. And then, of course, the financial impact. They come in with a huge bag of creams they've tried that cost hundreds of dollars in families who do not have a lot of discretionary income. So this is one of my important treatment pearls that we all do. It's quite simple, but it's something you could put into place in your own practice. We call this our rescue plan. So what will happen is patients will come to us and say, well, I've tried every cream, nothing works. And often what has actually happened is they've had either insufficient quantity of topical steroid or the incorrect vehicle or some combination of that. So I usually make sure the residents actually tell me like what exact steroid and what quantity did they use. There is this common fear that you can't use steroids in babies, that they're not safe, that you can only use mild ones, only over-the-counter hydrocortisone. In my opinion, over-the-counter hydrocortisone is basically useless. It's basically a placebo. So there is no reason we can't use, there's no potency limit depending on age. It depends on the morphology of the eczema. If the eczema is severe, you have to treat it in such fashion. I do not generally use topical or oral antibiotics unless I see a true infection. By that, I mean pustules or signs of cellulitis. So if I think somebody's infected, I'm always culturing that day and I'm treating to my culture. So we don't just treat empirically because we want to know what bacteria we're treating. Now, if you were to swab any kid with eczema, they're going to have staph growing on them. It's ubiquitous, but it is a chicken or the egg situation where the barrier being disrupted allows the staph to take hold and then it exacerbates the eczema. So the treatment is to fix the barrier, not to just treat staph with course after course of antibiotics, but you're not actually fixing the problem, which is the barrier. If a child is visibly infected, and that's a repeat thing, then I start to think about immunodeficiencies, especially in infants. Oral antihistamines, I'm going to get into that in another slide, but generally no for the treatment of eczema. If they have other allergies, it's a different story. And obviously you're going to screen, as you guys are experts in developmental issues, if you see something where you're concerned they're failing to thrive, they have other dysmorphology, then you're going to think about genetics, allergy, GI as appropriate. So the rescue plan is the following. We generally, and we're talking about severe eczema here where they have it, let's say 80% of their body is red and scaly. We prescribe a 1 pound jar of triamcinolone ointment. The reason is that it is a steroid that comes in a 1 pound jar, and we want ointment over cream because it's it will not burn. So always we use ointments in infants. We want them to liberally apply it anywhere, including face and scalp, groin, it doesn't matter, in this 2-week period. The key to this whole process is that it's 2 weeks and you're seeing them back shortly, because then you can see how the rescue worked and generally improve compliance because they know that, okay, just for 2 weeks, I can do this in a compliant fashion. After they've applied the topical steroid, we wait a few minutes and then we have a thick layer of a bland emollient such as Vaseline, and then put on cotton PJs, and that's it. And we do that for the 2-week time. And let me say, I didn't include this here, but we have them bathe first. So daily bathing, apply the steroid to all hot spots, apply the moisturizer, and then see them back. At that point, you'll be able, in the majority of cases, they'll be 90+% improved, and then you can implement some kind of maintenance. Now, if they still look terrible and they were truly compliant, which in most cases people were, then you know, okay, something is weird about this baby, they need to go to derm. So in terms of maintenance, we do have medications that can be used in babies that can be used that are non-steroids, which is a common request from parents. So crisaborole or Eucrisa is approved from 3 months of age and older, which is very useful. It's a very occlusive, thick vehicle. The downside is that it can burn terribly, which is why you don't use it on active eczema, because the children will scream and the parents will be very angry. So we use it as a maintenance. Once it's clear, if you know that like behind the knee always flares right back up again, that's a good place to use it. And the cost can be quite prohibitive, but generally if they've used a topical steroid, you can get a prior authorization to have this covered. The calcineurin inhibitors, they've been around, they're quite safe, they've been used for a long time, but they're approved only for 2 and older. And they do have a black box warning, which most of us believe to be spurious, about a risk of lymphoma. That's based on the oral use of calcineurin inhibitors, but nevertheless, parents may ask you about that, and they are also costly. This may not be something you're prescribing yet, but just so you're aware, there's a third kid on the block now called ruxolitinib, a JAK inhibitor, this type of different anti-inflammatory pathway. It's approved for eczema in ages 12 and up. Again, cost is a major issue, and it has a kind of scary black box warning, again, more related to the systemic use of these medications, but you may see patients getting these, so just so you're aware. Turning back to antihistamines, this is one of my personal bugaboos. The use of antihistamines is sort of ubiquitous, and yet we should think a little bit about like an oral medication that children are on chronically. Their evidence in eczema is really poor, and yet they're widely prescribed. The idea behind them, so non-sedating antihistamines do not treat eczema. The itch of eczema is not primarily histamine mediated. They don't really treat eczema. If you have concomitant itch from allergy, fine, go for it. But non-sedating are not useful. The sedating are helpful in the sense, if you want to call it that, helpful, that they will make children sleep. But do they really make them sleep? If you actually ask your patients, they'll tell you, yeah, they fall asleep, but they wake up a few hours later scratching. So it's not durable sleep. It's not real sleep, like deep sleep that children need. And long-term, it's not good for their brain to be having these sedating drugs every evening, especially if you're not actually treating their eczema with a skin-directed therapy. So we'll often have children on high doses of hydroxyzine, but they're on hydrocortisone 2.5%. So to me, that's a major disconnect. Like, we're scared to use a topical steroid at an appropriate potency, but we'll use a sedating drug long-term. So, and what brought that home to me in particular, and I'm definitely welcome, thoughts from the audience, is that there is some data about the association of long-term sedating antihistamines with the development of ADHD. Now, does that mean that those children's sleep was poor because they had genetic risk factors for ADHD? Obviously, this is a difficult thing to untangle, but if we can avoid those drugs and have better skin-directed therapy or systemic drugs for eczema, that would be preferable. Please ask about contact dermatitis. I spend so much of my visits going through like these minutia that seem like minutia, but can make a huge difference. Like, are you wearing perfume? I often am like, I smell perfume on you. I know you're wearing it. Do you use Glade plugins? And I don't care about the brand. Do you use a plugin? Do you have Febreze? Do you have any of these things? Because these are all fragrances. If you smell it, it's because there's molecules that are landing in your nose and on your skin. So we want to get rid of all of that. Are they playing with slime? Is that why they have severe hand dermatitis? Are you wiping them with some sort of wipe? For diaper rash, my first thing is always like, what wipe is it? Get rid of the wipes. So just to go back and to summarize with our pearls here, make sure you have enough quantity of steroids. So enough, if you give them 30 grams and it's involving their entire body, it's obviously going to be insufficient, and enough potency. Get rid of the contact allergens. Do excellent dry skin care. We use soap only in the genitals. People love to put soap all over and scrub the body. That's unnecessary and bad for children. No bubble baths. Make sure you have a bland emollient. And then another real important pearl that I see commonly, people will tell children they have horrendous eczema on their body, but they're like, no, don't worry, the scalp is cradle cap. And then they're giving irritants like Selsun Blue and Head and Shoulders, and the scalp is bleeding and so on. If you have an itchy body, your scalp is also eczema, especially in infants. So cradle cap generally wanes by 3 months of age. So these older children that have severe scalp involvement, they may have begun as cradle cap because there's data that shows that early severe seborrhea correlates to eczema development. But once they have eczema everywhere else, their scalp is eczema too. So you should treat it as such. And these shampoos like Selsun Blue has blue dye, it has fragrance, so they're generally quite irritating, and I don't recommend them. Real cradle cap early on, go for it. Treat it as you'd like. This is another baby, our second baby who's itchy. So it's a 3-month-old, this diffuse eruption, these scaly plaques, and also what I'm calling juicy crusted papules. They're involving in the axilla and the groin. Someone thought it might be eczema, gave them hydrocortisone, which didn't work. Dad is also itchy and has a rash. What do you think the next best step could be? Yeah, so scabies. So let's hope this works. I'll be so sad if it doesn't. So this is what a scabies mite looks like under the microscope. They're alive. My favorite thing to do in clinic is to do a scabies prep and actually bring the family into the scabies, and we'll treat it properly. So they're alive. They will stay alive in that mineral oil for 2 or 3 days. So can imagine what the itch they cause. All right, let's keep it moving here. Sorry, I don't know why it went backwards. Come on. Okay, yeah, so scabies. I don't know what just happened. So scabies basically, so you want to think about scabies when you have multiple family members that are involved. Generally, these are going to be like very juicy bumps in infants. They have the inability, I should have had a slide for this. They can't scratch like adults, so they have a much higher mite burden. So you may not see burrows in the child, but these juicy nodules, especially in the axilla and groin, should clue us in that the child may have scabies, and then they need a mineral oil prep, and then the entire family needs to be treated, including anybody who might be a caretaker. So there may be grandma doesn't live in the home, but if she's holding the baby all day, she needs to be treated as well. Okay, so we're going to switch gears here to scaly scalps in pre-adolescence. So these are 3 examples of different scaly scalps in children. So with the green wall background here, you can see some faint scaly patches all throughout the scalp. And that's tinea capitis. It can look like fine powdery scale. It can be there for years because it will be undertreated or treated only topically. So don't discount it even if it's been there for years. On the other hand, thick, sharply demarcated plaques with erythema, especially at the borders of the scalp and behind the ears, that's more typical of scalp psoriasis. And then there's this lesser known condition, but I've been referred several times, children with what we call pityriasis amiantaceae, these yellow, thick, adherent, they call it asbestos-like scale. I don't know what asbestos looks like, but that's what it's called in the book. And that's also a variant of scalp psoriasis. So just if you have a child where it doesn't seem to make sense that it would be tinea capitis, the most important thing to do is go ahead and culture it and see if it is or isn't, so you know what you're treating. So not that you will see much pediatric psoriasis, although we've been inundated lately, which is interesting, but I want you to have a sense of it, to recognize it in case you do, to refer to us. Any child with psoriasis should be referred to derm. It's rare enough that it needs to come to us. So facial involvement is quite common. So if you have a weird rash, especially eyelids, it's something to consider, and it can be misdiagnosed as eczema. So I will look elsewhere for signs of psoriasis. And children often have what we call inverse psoriasis in the genitals and axillae. So if you see a persistent rash there, at least have psoriasis on your radar. And in that certain scenario, I'm checking their scalp. If I see psoriasis there, I'm checking their nails, and I'm asking about family history. It's not always present, but if there's a strong family history of psoriasis, it's going to make us think about that more. And we treat children just like adults. That's the theme of pediatric dermatology. If they have bad disease, we give them drugs. And if they have mild disease, we give them creams. Guttate psoriasis is often talked about in children, this more rainbow raindrop type presentation. Can be triggered by infection, but once it's triggered, you often have lifetime psoriasis. In other words, it's rare that you remit, but in some cases you might. Treatment of the strep, if that is the trigger, is not clearly going to remit the psoriasis, but obviously you should treat it. Some of these kids are just colonized by strep. So there were papers on tonsillectomy or not, and it hasn't really borne out. If they need a tonsillectomy because they need one, then they should get one, but not necessarily for the psoriasis alone. And many of them go on to develop chronic plaque psoriasis. Very important to recognize diseases in different skin types. In patients of color, things will not have, erythema will not look the same way, will be more purple. And there may be a different kind of scale. So just keeping in mind that to keep that on our radar. So if a rash is weird and long-standing, send it to derm if we're not sure. Adolescents are different from pre-adolescents. So once you are an adolescent, it's much less likely that you'd have tinea capitis. The sebum that you get from puberty is protective. So you will see, however, seborrhea quite common in our African-American patients. And so it's important to recognize it and treat it. And it can often involve the face as well, such as the eyebrows and the nasolabial folds. It's unrealistic to ask our patients to wash their hair more frequently. That's advice that can be given and is, it kind of shows a lack of cultural competency because it's very damaging to the hair to wash very frequently in some patients. Everybody's hair texture is different. So we often ask the patient, how frequently are you comfortable washing the hair? We aim for once a week when it's quite inflamed. We want to make sure we're using shampoos that are not damaging to black hair. So ketoconazole notoriously drying and breaks textured hair. So we like to go for either over-the-counter products that are meant for textured hair, such as Head & Shoulders has created a line called Royal Oils that is reasonably priced. There is a prescription shampoo, cyclopyrox, but hard to get it, so you often need to fill out a prior auth. And then it's really important to also treat the inflammation. So this is not just scale. There's also often substantial erythema, itch, and so on. So in that circumstance, you need a topical steroid, and the vehicle of that also depends on the patient's preference. So I might ask the patient, do you prefer an ointment? Would an ointment or a grease work with your hair type, or do you want a liquid? And then the patient's going to help me decide. There is also a steroid oil called fluocinolone oil, but again, difficult to get covered, but often can work well. Coming up on our last two slides here, these are just for fun because we see this a lot in the summer. Phytophotodermatitis, you look like a hero when you make this diagnosis. So this is basically from certain plants, often limes or lemons, that have photosensitizing compounds. So in this case, this kid sucked on a lemon and had these drips down his chin. You might have it on the arm. They call it the other Lyme disease, like, to be funny, LIME. You go to Mexico for spring break and you squeeze a lime and there's drips all over the arm. But what you should recognize in terms of the morphology is that this is obviously something external. Your body can't make like geometric shapes. So something external occurred and it'll be red when it started, then hyperpigmented. So this is phytophotodermatitis. We just, one of our nurses came in and she was like, I don't know what this thing is on my arm, but I was in my garden. I was like, before I see you, I know it's going to be phytophotodermatitis. And when she looked in her yard, she realized she had fig trees and the fig trees have this compound. So it can be weeds as well. It doesn't have to just be things like lemon or lime, but those are the most common that we see. So you can't do much about this besides sun protect, but it's nice to reassure the family. And our last kind of fun one to recognize, and you don't have to refer, is lichen striatus. We see it all the time. It's an acquired, harmless Blaschko linear disorder. So Blaschko's lines are these swirling lines on the body that reflect the way the epidermis was formed in utero. So birthmarks occur along those. You guys have seen those, these swirls of pigment, swirls of bumpy birthmarks like epidermal nevi, but you can also get acquired rashes. So this one is called lichen striatus. It occurs generally in elementary school aged kids. It'll be a few bumps that start and then they extend in a line. So extending in that linear swirling line is what tells you it's lichen striatus. In skin of color, it's often hypopigmented. In white skin, it may be kind of pink colored, and they're flat tops. That's what lichen means in dermatology, the appearance of it kind of being these flat top papules. And if they're involving an extremity, you may see nail dystrophy, linear nail dystrophy, which this child has, contiguous to the rash. And the lines on the face are much more complex. As you can imagine, facial formation in utero is more complex. You'll get these other swirling lines. Mainly as a pediatrician, if you recognize this, then you can tell them it's lichen striatus, it's harmless, it will go away, and reassure them, which is what we would do in dermatology. We would not biopsy, we would not treat it, we would just provide reassurance. So you guys can do that beautifully on your own. And with that, I will conclude and take your questions from me and Dr. Habeshian. Thank you.
Thanks, Dr. Habeshian, Dr. Kikorian. We're running on a tight schedule. Are there any questions? Great. Just a reminder for folks who've asked here in the audience and on our online audience, we are recording these sessions. We will be able to post them on the Pediatric Health Network website for you to look at asynchronously, or your colleagues or partners in practice as well. One question?
I have a couple questions here on the Zoom. I think these can go relatively quick. The first is, how long does phytodermatitis last for?
Okay, so the initial inflammation is quick because it's just a photo response, but then the PIH, the post-inflammatory hyperpigmentation, can last months depending on how much sun they got, the skin type that the person has. So you just have to, like anything, if you pick a pimple and you get a brown spot, it's going to last you several months. So especially if you have skin of color. So for that reason, you really want to sun protect and give it time.
Great. I have two questions here related to drugs. So hopefully we can go quickly on these, but you may say this is a longer conversation. The first is, can you comment on Dupixent? How effective, what is the youngest age to use this? And then the second is, what precautions for Accutane use?
All right, I'll take the first so Kai can finish up. So Dupixent, I should have included a slide. So this is very exciting news. This is an FDA-approved biologic drug. It blocks a pathway of inflammation specific to atopic dermatitis called IL-4 and IL-13. Life-changing, life-altering. Literally, people who did not go to school for a year are back in school. Like, for us, it is a miracle, and it is FDA-approved as of this month down to 6 months of age. Miracle, life-changing. And now there is actually another drug, upadacitinib, approved for 12 and older. So for the first time, we have 2 FDA-approved drugs in childhood and multiple coming down the pipeline. So please, any severe atopic derm kiddo, send to us. Really can make a big difference. So thank you for that.
Yeah, and precautions with Accutane, that's a good question as far as lab monitoring, if that's sort of what the question was getting at. There's a lot of evidence that shows no need for lab monitoring in an average healthy patient without underlying risk factors for liver disease or elevated triglycerides. That being said, what we routinely check is AST, ALT triglycerides upon starting, and then about 2 months after initiation. It can cause some transient increases, but basically the literature is suggesting that it doesn't really almost never changes management, which is why, it's not as critical as maybe we once thought it was. And Yasmin has found that as well.
Yeah,
from
I
her
just wanted to
her
comment.
data.
Yeah, I just wanted to say about the triglycerides. So the concern is like, why do we even care about triglycerides? I sometimes ask myself, like, if we're monitoring labs, what is the purpose of the lab? In that case, it's the concern is pancreatitis from elevated triglycerides, which has never really been reported in childhood. So yes, we have to monitor it, and we do modify drug dosing if the triglycerides are elevated. But in a paper we just had accepted, we never saw a child that needed to stop therapy due to elevated triglycerides, and 0 had complications. So yes, we monitor them, but with this concern for pancreatitis, but it is not really something that we expect to really ever see.
Thanks.